the last two lectures today are the kind of work that I do, sort of stuck in the office upstairs on the computer. So it's all sort of the numbers stuff. And the first lecture is about treatment planning and specifically about safety planning. So we've heard already Dan giving the lecture on keratoconus screening, and obviously that's kind of the key pillar for safety when it comes to preventing ectasia. And the other main reason for ectasia is excess keratectomy. So if you remove too much tissue, obviously then that weakens the cornea to a point where ectasia might occur. And then obviously there are some other unknown causes potentially. And actually both of these causes were originally identified from Barraquer in his original work with keratomileusis. So in his textbook he describes how ectasia was more likely to occur in steep corneas, which is essentially the forerunner to, i.e. they were probably keratoconus, a lot of these cases. And obviously he then also described the excess keratectomy, so he was the first one to describe, put a limit on how much tissue you could remove, how thick his capillary section could be. And in terms of keratoconus, the other thing that's really coming to the fore more and more is the risks associated with eye rubbing. Damien Gattinel recently published a really excellent review article, and his hypothesis actually is that eye rubbing is the root cause of keratoconus, which is an interesting thing to look into further. But certainly there is definitely a relationship between vigorous eye rubbing and keratoconus. And obviously, so this is a very important message that we should be communicating to our patients that after laser eye surgery is don't rub your eyes, because if you rub your eyes, you could get ectasia, okay? So this has to be a very big part of the patient counseling, both before surgery, in your written documentation, and also repetitively reinforced at the post-op consultations. And I've got a photo of Arthur Cummings here because he has a video on YouTube which is the best kind of explanation I've seen of how to communicate it with a patient. So patients who really rub their eyes, they're not just going to stop rubbing their eyes just because you tell them, because they need that satisfaction of rubbing their eyes. But he calls it the finger to bone technique, where don't rub on your eyes, but if you push and rub on the bone, on the nose or sort of around the eye, then you can get the same kind of satisfaction of relief, but you haven't actually put any force onto the cornea. So it's definitely worth a watch. Arthur explains that really nicely. So what we're going to focus on here, though, is talking about the residual stromal thickness and making sure that we don't remove too much corneal tissue and that we leave enough behind to maintain the strength. The residual stroma is a very straightforward calculation. We've all done it countless times by now, I'm sure. But just to run you through, so what is the residual stroma? If you take the full corneal thickness, and then you've obviously got your flap, so you're cutting the flap, so everything in the flap is now not contributing to the strength of the cornea anymore. And then obviously you're going to ablate and remove some tissue. And then the RST, the residual stromal thickness, is all of the stroma that's underneath the ablated region. And so that's very straightforward, but the key point for safety is to understand that each of these three elements, the corneal thickness, flap thickness, ablation depth, all have some kind of error associated with them, be that measurement error or an error in the actual, how much ablation actually occurs, how thick the flap actually ends up being. And so we have to take all those potential biases, that potential error into account. And so, yeah, so this is really the key point of the lecture. The safety calculation is only a prediction. And the achieved RST is most likely going to be different to what you wrote down on the sheet of paper. So when you do your safety calculation, just remember that this is only what you expect is going to happen. And so you can't base any future treatments off of that predicted value. You're going to want to measure the RST that you actually got post-op, when it comes to retreatments, that is. And the great thing is that OCTs are now so widely available that we can actually get this information. You know, when we were giving this lecture 10, 12 years ago, it was a totally different story. So the safety of LASIK, because of OCT and because of ultrasound, has been dramatically transformed. So what is the risk of leaving a very low RST? What's the risk of leaving less than 250, which is, you know, the widely recognized limit? What's the risk of leaving less than 200? These are questions that we should be in the forefront of our minds when we're talking about safety. So just to go through some definitions of what we're talking about, the main two principles are accuracy and precision, and they're slightly different things. So it's a good idea to just remember exactly what we mean by these terms. So the first term is accuracy, and here we have a target. And if you miss the center of the target, that is really how accurate you're being. So to define it, accuracy is the degree of conformity of a measured quantity to its actual value. So in terms of this picture, it's how far away from the bullseye were the cluster of points. And this is quantified by the bias, which is the mean of the difference between the measurements and the reference value. Precision is slightly different. So precision characterizes the degree of mutual agreement among a series of individual measurements. So in terms of our diagram, that's how close together all the points are, all the gunshots. And it's quantified by the standard deviation. Okay, so how do we take this into account in terms of a LASIK safety calculation? Well, flap thickness is really the key element to our safety calculation, because this is the element that is associated with the largest degree of measurement error, okay? So with any microkeratome or femtosecond device, there is a labeled flap thickness, or with a femto, obviously you're programming, excuse me, you're programming a specific flap thickness that you're aiming for. So, for example, the microkeratome may say that it's a 130 micron flap, but actually it cuts thinner than that. So it's a 110 micron flap. Okay, so there's an accuracy bias here, which is actually in your favor, because every flap that you make is actually thinner than what you wrote down on the piece of paper. So this is helping you be more safe, okay? But there are other microkeratomes, or have been, or sometimes a femtosecond laser, where it says it's a 130, but actually, on average, it was cutting a 140 or a 150. So every time you wrote down 130, actually, you were underestimating the flap thickness. And so there's a safety risk. So it's very important to know the mean and standard deviation of the flap cutting device that you use, so that you're aware of what your bias is. And when it comes to standard deviation, this is always a really good thing. You learned it a long time ago, but it's a good rule of thumb to kind of keep in your head, so that whenever you're looking at any data with standard deviations, if you remember the rule of thumb that one standard deviation is 68% of values will be within one standard deviation, 2 standard deviations, 95%, and 3 standard deviations, 99.7%. So 68, 95, 99. So whenever you see a standard deviation, you can quickly kind of go, okay, so if I times it by 2, then that's pretty much all the values are going to be within that range. So that's a good rule of thumb to remember and keep in your mind. So let's just go through a couple of examples to see how this manifests actually in the clinic in terms of planning a treatment. So let's say we had a case which is 530 pachymetry corneal thickness, and we're going to do a 160 micron flap. So we're kind of talking old sort of Hansetome, microkeratome days. And we're doing a 90 micron ablation, and we've got our minimum 250 limit that we don't want to go under. And so if we do the maths, subtracting the flap and the ablation, the RST is 280. So on the face of it, we're happy, and we're well above the 250 limit. But the older microkeratomes, some of them had standard deviations of up to even 30 microns. So if you do a 3 standard deviation error, there's a potential for a 90 micron error. Yes, that's in that 0.5% at the very end of the bell curve, but it will happen eventually. And so we need to take that into account. And so actually, with this setup, the lowest possible RST is actually 190 microns. And so there you can understand where these cases of ectasia can crop up with the use of flap cutting devices with that much measurement error. So obviously, how can we solve the issue? Well, the easiest way to solve it is to do a thinner flap. And femtos, have been like a magic trick in that respect. We can make very thin flaps now. So if you take that same example and make the flap thickness 100 microns, even with a standard deviation of 30, the lowest RST is still 250 microns. So there's no chance, even in that 0.5%, of going below your 250 limit. But obviously, what happens is if you use a thinner flap, now you're bringing into play the second factor, which is the epithelium, because you don't want your flap to go into the epithelium or even buttonhole completely out. So if you've got the measurement error works in both directions, right? So if you've got a 90 micron potential error on your RST side, you have the same amount of error in the buttonhole side. So that's why you couldn't do such thin flaps with microkeratomes because of that measurement, the flap thickness error. So it's very important that we need to reduce the standard deviation of the device. And if you reduce the standard deviation to 10 micron, plus or minus 10, then 3 standard deviations, then 30 microns, and now even our first case is safe because our RST of 280, the worst case, if you subtract another 30, is still 250. Okay? So this is what you need to be thinking about, is what is the worst case scenario? And the good news for all of us is that these devices, the microkeratomes and the femtosecond lasers, have been significantly improving the technology-wise over time. So this is a graph that we plotted a few years ago where we took all of the published studies of microkeratome and femtosecond laser flap thickness standard deviation and plotted them over the year that they were published. And you can see that there's a trend over time for that standard deviation to come down and down and down. The other thing that you can see is that the red line, the femtosecond laser, has always been lower, as in more precise than the microkeratomes. But even femtosecond lasers have been improving over time as well. And now the femtosecond lasers are down to less than 5 micron standard deviation. So we're getting extremely precise flaps now. So a lot of the treatment safety planning is made significantly easier because of the technology that we're working with. And because of that, it enables even thinner flaps. So with the VisuMax, because this has a 4.4 micron standard deviation, we can make a flap that is 80 microns very safely, because even with 4 standard deviations, that's 16, 18 microns. If you have an 80 micron flap, you're not going to be going into the epithelium. Okay? So this is transformed LASIK especially for higher myopia, higher corrections, where you can go down to extremely thin 80 micron flaps. These are slightly harder to manipulate, so I wouldn't suggest you start out on the 80 micron flaps, but it is definitely something that you can work up to. So like I said, the golden rule is that you must always assume the worst case scenario. So you always want to add all of your errors together and assume that they're all going to happen in the same eye cumulatively, and that's then, if you then use that as the number that you write down on your piece of paper, you know that it can't be thinner than that. And so that's then the most safe approach that you can take. So yeah, like I said, so we're going to calculate the lowest possible RST. We're going to assume that the corneal thickness has overestimated the true value. So this is slightly old actually, because most of us are using OCTs now. So with the OCTs and the ultrasound devices, the pachymetry values are accurate enough that I wouldn't suggest changing anything. But from our previous studies, Pentacam certainly tended to overestimate the corneal thickness by about 15 microns when we compared it to very high frequency digital ultrasound. So if you're only using Pentacam, then I would recommend that you subtract 15 microns from your corneal thickness when you're doing your laser treatment safety calculation. Just, again, assuming the worst case scenario that your device made the measurement too thick, okay? Know the mean and bias and reproducibility of flap thickness for the device that you're using, be that a microkeratome or femtosecond laser. Most of these devices have publications that give you this information, or you can go to the manufacturer and ask for it. And then you can factor those in. What you want to do is you always want to add the bias. So I talked about what's the label, what's it actually doing. So add that difference into your calculation, and then add at least 2 standard deviations onto your flap thickness. So for example, for us, if we're doing a 100 micron flap with the VisiMax, we will add 18 microns to that in our calculation. So we're assuming the worst case scenario that the flap is going to be that 1 in 1,000 flap of being 18 microns thicker than you thought it was, okay? So it's just always assume the worst case. Then ablation depth is the third element. This is a little bit more tricky because it's very difficult to know, it's very difficult to study what the actual ablation depth achieved was compared to what the laser says it was going to be. So that's a little bit more tricky. We have actually analyzed it using very high frequency ultrasound, looking at the change in stromal thickness before and after surgery and comparing that to the laser printout. And for the MEL, we found that the stromal change was actually less than what the laser was saying that it was going to be. So now that we know that information, we're able to take that into account into our safety calculation. But there aren't many lasers where this study has been done. Okay, so slight change of tack, but it comes also into treatment planning. This is the additional part of treatment planning in terms of safety that is relevant for hyperopic LASIK in particular. So hyperopic LASIK, we'll go into the history. So it's about understanding the limits of how much you can steepen a cornea, okay? Because we know that excess steepening can lead to the epithelium breaking down. And so historically, traditionally, we've used a keratometry value limit as saying, some would say 49 diopters, some say 50, 51. Don't aim to steepen a cornea beyond that limit, okay? So, and what you want to do is calculate it based on, this graph is showing here. So the more that you, obviously the amount of treatment that you're doing is correlated to the amount of steepening that you're making on the cornea, okay? So It's not exactly a one-to-one relationship, but for a safety point of view, it's easier to assume it's a one-to-one relationship, because then you're assuming the worst case scenario. It's actually less than that. It's about 0.75, as you can see on the regression line here. So you actually get less change in diopters on the cornea than the amount of diopters you're treating. Part of that's because we're talking about refractive plane and corneal plane, but also even taking that into account, actually the dioptric change is slightly less than the refractive change. So all you can do is basically you take your pre-op keratometry and you add the amount that you want to treat, and that's then what you expect the post-op keratometry is going to be. And as long as that's less than 49 or 50 or whatever you take your limit to be, then it's safe to go ahead with the procedure. You don't want to fall off the cliff. So what are we trying to avoid? Well, we're trying to avoid apical syndrome. So like I said, if you have excess steepening, then the epithelium is going to get thinner where in that central region where the cornea is steeper. And the problem is the epithelium is made up of, it's about 7 cells thick in a normal eye. And so obviously a thinner epithelium essentially has fewer cells within that layer. And it gets down to the point where there's not enough cells for it to kind of stick together and stay robust. So there is a safety point for thinning. There's no safety point for thickening. The epithelium can thicken as much as it wants because it's just adding more cells and there's no risk of breaking up. That's why it can fill in, 100, 200 micron holes even in the cornea. But there is a risk if you're making the epithelium too thin. So that is what we're trying to avoid. Now, what we looked at was the epithelium in eyes after hyperopic LASIK so that we could see and quantify the change that's occurring. So this was the study that we did using the ultrasound device. We were looking at hyperopia of mean of +4 up to +7. And this is the average map of the epithelium for that population. And so obviously, like I said, where the central areas become steep, you're going to get thinning of the epithelium to compensate for it partially. And in the peripheral areas where you've removed tissue, you're going to get compensatory thickening of the epithelium. So you get this donut pattern, very similar actually to what you see in keratoconus earlier, but for a different reason, obviously. And so yeah, so here's the cross-section scan showing that thickening in the periphery, thinning in the middle. There we go. So now, okay, so then we're looking at the population, and what we did was we plotted the amount treated on the bottom on the x-axis, and we then plotted that against the epithelial thickness. And we looked at the thinnest point centrally and the thickest point in the periphery. And you can see from the graph that as you treat more, it makes sense, the more you treat, the more epithelial change that you get. So there's more central thinning as you treat more hyperopia, and there's more peripheral thickening. But it's really the central thinning that's kind of the risk factor, okay? So this is what we need to focus on. And what the next thing we did is, instead of plotting that and correlating that with refractive change, we correlated that with the post-op keratometry, because the post-op keratometry was what we thought was the safety limit, okay? So we want to look at, is that really a viable safety limit, or actually, is the epithelium a more reasonable measurement to be looking at, because the risk is about epithelial breakdown because of steepening. Steepening is just the cause that makes the epithelium thinner. So if you can measure the epithelium, then you're measuring the actual problem, okay? So what we did is then we plotted this against keratometry against epithelial thickness, and there was you get the same trends. Obviously, the more that you treat, then the steeper the post-op cornea is going to end up, and therefore there's thinner epithelium. So you did see the same correlation, and the same thing with the thickening epithelium. But if we take a closer look at the graph, we can look at some specific examples. And this is where you see the discrepancy. So here's an example where the keratometry, this is post-op. So we've done a hyperopic treatment already. Okay? Post-op SIMK is 41.5 diopters. Now in anybody's book, that's flat. Okay? You're not going to be worried at all if you're about to do a retreatment for that patient. You're not going to think, oh, I might get apical syndrome if I do some more hyperopic treatment. But if you measure the epithelium in that case, it was 26 microns. And that's right on the limit of where you're running out of cells and it's going to break down. So based on epithelium, we now know no way should we do any more hyperopic treatment for that case. But based on keratometry, you would have merrily gone along and said, yes, fine, you can go and have your retreatment. So this is an example where the epithelium is really playing a role in safety for retreating in hyperopic cases. Obviously, you get what we would expect. Post-op SIMK, 49 diopters, steep, getting towards the limit of where we don't want to go above. And yes, the epithelium was thin, but we confirmed it with the epithelium, and so we know no more steepening in that eye. Okay? And then you can get all these the other combinations. So yes, you can have a very steep case, 50 diopters, but so based on keratometry, you'd say, sorry, no more retreatment, no more hyperopic correction. But based on epithelium, there's plenty of room, there's tons of room. The epithelium is only 44 microns, so we've got another 14 microns to play with safely without any risk of apical syndrome. It's very simple. Just measure the epithelium and you have the answer. So that's kind of the way it goes. Even the steepest case was 52 diopters post-op. It was steeper than we expected it was going to be. We didn't aim for it to be 52 diopters, but that's where it ended up. But the epithelium is sitting at 36 microns, so it's still in a very safe place. Okay? So it's this balance between epithelium and keratometry. So in summary, the epithelial changes are central epithelial thinning, peripheral epithelial thickening, compensating for the ablation. Epithelial changes are proportional to the amount that's treated. They're also proportional to the post-op steepness, the SIMK. But you can get a flat cornea that has a thin epithelium. And so those are the cases where you know I'm not going to steepen it anymore, even though keratometry says I can. Or you can have a very steep cornea where keratometry would say you can't treat, but epithelium says it's totally fine, the epithelium's thick and healthy. So that's going to wrap up the first lecture. So has anyone got any questions on what we've gone over here? Or we can